intraocular hypotensive drugs because they are known to reduce the intraocular pressure in the eye. So what's glaucoma? So glaucoma is any group of eye disorder characterized by high intraocular pressure. So sustained increase in the intraocular pressure can damage the optic disc, can harden the eyeball, and can lead to complete or partial loss of vision or what we call blindness. That's why untreated glaucoma can lead to irreversible blindness due to the damage in the optic nerve. So there are two types of glaucoma. We have the open angle glaucoma, which is characterized by increased production of aqueous humor. Okay? Increased production of aqueous humor leads to increased intraocular pressure. An open angle glaucoma is said to be chronic in nature. So we treat it with drugs. Gumagamit tayo ng gamot para ma-manage siya. However, for angle closure glaucoma, okay, in simple terms, there is a drainage problem. Okay, there is a drainage problem in which there is blocked trabecular meshwork of the Schlemm's canal. Okay, so this type of glaucoma is not chronic in nature. This is usually an acute case, okay, which is considered a medical emergency. So dahil medical emergency siya, we don't usually treat it with anti-glaucoma agents, but we subject the patient to surgical intervention. So the most important treatment for angle closure glaucoma is surgery. For the open angle glaucoma, we can use all that I'm going to discuss here as the anti-glaucoma agents. So here are the classes of the anti-glaucoma agents. So we can uh, differentiate them, okay, into two major groups. Okay? So dalawa daw po yung major groups. Number one is those that can decrease the production of aqueous humor. So sino po ba yung mga gamot that could reduce the aqueous humor? Number one would be the beta blockers. So sila yun, or the beta adrenergic antagonists. Okay, the second one would be the alpha 2 agonist. Okay, or the adrenergic agonist. Okay, yung mga selective. Selective. Okay, the third group would be the carbonic anhydrase inhibitors, or the CAIs. We call them CAIs, or the carbonic anhydrase inhibitors. The second group of drugs that we use, okay, are called drugs that can increase outflow, okay, of aqueous humor. So how can they increase the outflow of the aqueous humor? They increase the uveoscleral outflow. Okay, so who are these drugs? The first one, okay, would be the prostaglandin analogs. Okay, so the prostaglandin analogs are known to increase the uveus scleral outflow together with, okay, the adrenergic agonist, but only the non-selective ones. So yung mga non-selective, sila yung mga nag-i-increase ng uveroscleral. Like for example, the one I told you before sa autonomic drugs, the epinephrine or epinephrine. Okay? And of course, the myotics. Okay? Or the cholinergic agonists. Or we can call them the parasympathomimetics. So these are the uh, two main groups of drugs. So we can lower the intraocular pressure on these two ways by decreasing the production of the aqueous humor or by increasing the outflow, the uveoscleral outflow of the aqueous humor. Both will reduce IOP. So let's proceed with the prostaglandin analogs. So the prostaglandin analogs are literally analogs of prostaglandin, particularly what prostaglandin. The prostaglandin is known as prostaglandin F2 alpha, okay? F2 alpha, yan siya, okay? So all of them are prodrugs, okay? They're analog of the prodrug prostaglandin F2 alpha isopropyl ester. So when these prostaglandin analogs are stilled, okay, into the human eye, they are converted to their acid form. Okay, the acid forms uh, is the one that is pharmacologically active, which acts on, okay, the FP receptor. Okay, FP receptor on the ciliary muscle. So binding of the drug in the FP receptor would increase the uveoscleral outflow. Okay? So, ano po ba yung FP receptor na yun? The FP receptor are just the receptors of the prostaglandin 2 alpha in the eyes. Okay? So, that's how these prostaglandin analogs work, okay, based on their molecular mechanism. So, they are prodrugs. That's why they have a good bioavailability when administered topically. So, sino-sino sila? So, the first one that we have here is latanoprost. Okay, so latanoprost is the most popular among the prostaglandin analogs. The brand is Salatan. We also have travoprost. Okay, and the other one is bimatoprost. So bimatoprost is uh, not the same uh, structure with latanoprost and travoprost. It's unique. Okay, it's a specific prostaglandin analog called prostamide. Prostamide. So it's a prostamide. So prostamides are like members of the fatty acid amide family. So it's a synthetic analog that mimics the action of uh, prostamides inside the body, which could also effectively lower the intraocular pressure. Okay, so that's it. Ano bang advantage ng mga prostaglandin analogs? The number one advantage of giving prostaglandin analogs is their convenience. Bakit sila convenient? Because they are useful as once a day administration in the treatment of glaucoma. Okay. Aside from that, they have superior, okay, efficacy as ocular hypotensive agents. Aside from having superior efficacy, they also have good safety profile. So anong ibig sabihin ng good safety profile? They have documented uh they have no documented bad or severe adverse effects. Okay, so those are the three advantages of the prostaglandin analogs: the convenient use as once daily administration, superior efficacy, and then good safety profile. That's why right now the prostaglandin analogs are considered as the first line treatment for most patients with open angle glaucoma or those with ocular hypertension. Okay, so compared to the other drugs, so yung pangalawang sikat aside sa mga prostaglandin analogs, yung mga beta blockers like timolol. So sa timolol kasi, this is given twice a day. Okay? And compared with timolol, which is twice a day, or the other beta blockers, the prostaglandin analogs are applied once a day, okay, uh, which can be administered any time of the day, okay? Mm. Kasi si timolol, okay, bakit mo siya binibigay kahit gabi? Because uh, timolol does not uh, usually uh, work during the night. Okay? So, unlike yung mga beta blockers, mm, they could not, based on clinical studies, the beta blockers could not provide uh, effective lowering of intraocular pressure during the night as during the day. So, good yung mga beta blockers for the urinal uh, intraocular pressure control. The urinal is like uh, during the day. Pero pag nocturnal, yung mga beta blockers, they have reduced ability to lower the intraocular pressure. So unlike the beta blockers, the prostaglandin analogs are convenient because you just administered them once and then they provide better diurnal IOP control, okay? Uh, diurnal IOP control, yeah. So pwede mo silang i-administer anytime, kunwari gabi, binigay mo siya gabi, until umaga na siya magta-take effect. Okay, clear? So that's the advantage of the latanoprost and the other prostaglandin analogs. That's why they have they are considered now as one of the first line agents. So what are the known side effects? I told you they have good safety profile, but perhaps the most unique of these side effects that were documented is the darkening of the iris color, which occurs approximately 5 to 20% of patients. And this is developed after like 4 weeks of treatment with, okay, latanoprost and other uh, prostaglandin analogs. But some patients develop it after several months after initiation of latanoprost therapy. Okay? Yeah. Ano pa? Latanoprost is also known to increase eyelid pigmentation and ito yung good thing din sa kanya. It can cause hypertrichosis. So yung pilik mata mo kakapal pag nag-administer ka ng latanoprost or other prostaglandin analog. So it's also has a cosmetic side effect. So kumakapal yung pilik mata ng mga nagte-take ng latanoprost. Okay, some patients also develop conjunctival hyperemia and allergies. Okay, and then the others, these are very rare side effects. So they were documented in rare occurrence to some patients uh, who undergone or underwent prostaglandin analog treatment. But again, overall, they exhibit good safety profile. Okay, so that's for the prostaglandin analogs. Let's now move on to the beta receptor. Okay, beta adrenergic receptor antagonist, or we call them the beta blockers. Okay, so let's focus only on the beta blockers which are used for glaucoma. So again, we have selective and non-selective. So pag sinabi nating selective, they only bind to the beta 1 receptor. So siya to. Okay. And the rest are selective beta. Sorry. And the rest are non-selective beta blockers. Highlight natin. Yeah. Because they have affinity on both beta 1 and beta 2. Okay. And then the other one, which is highlighted, is it's a partial agonist because it has intrinsic sympathomimetic activity or ISA. So binanggit ko na po what does ISA mean, right? So these types of beta blockers, they have advantage of lesser side effects than other beta blockers. Okay? So, sino po ba yung mga non-selective natin? So that includes timolol, levobunolol, okay, metaproterenol, and carteolol. According to studies, okay, the non-selective beta blockers are more superior in terms of lowering the intraocular pressure than the selective beta blockers. However, taking the non-selective beta blockers could have systemic side effects such as shortness of breath. So this could be potentially disadvantageous for patients with asthma. Okay, asthma and COPD, because the non-selective beta blockers could block the beta 2 receptor. Okay, so ano bang meron sa mga beta blockers? So along with the prostaglandin analogs, beta beta blockers are also among the most effective ocular hypotensive agents in patients with primary open-angle glaucoma or uh, like incidences of ocular hypertension. So clinically, they are widely accepted because of their efficacy. However, one of like the hassles in uh, prescribing or using the beta blockers is the twice daily installation. Okay, so installation. Ayan. But their advantage is they have like similar with the prostaglandin analogs, they also lack untoward ocular side effects. So they also have good safety profile. Okay? Yeah. So ano yung kanilang mechanism of action? Okay, blocking the beta 2 receptor in the ciliary body will reduce the secretion of aqueous humor, therefore lowering the intraocular pressure. Okay? So, the beta blockers na nabanggit ko na yan, ginagamit sila for primary and then primary open angle glaucoma. We can also use them for many secondary glaucomas. So, ibig sabihin ng secondary glaucoma, like other disease, okay, or like a drug can cause glaucoma. So, that's called secondary, okay? Ano pa? Uh, Beta blockers, especially timolol, is also used or effective for the prophylactic treatment. Okay, so prophylactic treatment din siya of elevations in IOP after laser treatment, including cataract surgery. Okay? Sige. Baka may tanong kayo na, Doc, what if I'm already taking like tablet, yung oral or per-oral beta blockers, and then I have timolol as my drug. So tingin niyo ba, will there be like additional benefits in lowering the intraocular pressure? Yes or no? Mhm. Can I see your opinion? You are already taking oral beta blockers and then you added timolol. Will that provide additional intraocular pressure lowering benefits? Yes or no? Okay, yes. Yeah. Sir, how about in terms of the side effect? Okay, based on the clinical studies, there is no notable increase systemic beta blocker related side effect if you are taking per-oral beta blockers and then topical timolol. So, yun po yung based sa result ng clinical study. So, only the added benefits, okay? So, it could provide like a modest additional intraocular lowering benefits, okay? Without side effects. So, it's okay. Hindi kailangan itigil yung oral beta blockers and switch to other agent. Okay. Next, side effects. So, ano ba yung mga common side effects ng mga beta blockers? So, usually, mga doc, local reaction can occur with the administration of the beta blockers. So, this allergic reaction manifests as the blepharoconjunctivitis. So, this is usually accompanied by erythema and edema of the lids. Okay, so the reaction can occur as early as first month of the therapy. So how do we address the blepharoconjunctivitis? So if you like experience this to a certain beta blocker, we can change to another beta blocker or other class of anti-glaucoma agents to manage the allergic reaction. Okay? Ano pa? Others include dry eyes or decrease tear break-up time, corneal anesthesia, okay, macular edema, macular hemorrhage and retinal detachment, uveitis, and cataract progression. When beta blockers are given by topical route, again, kahit topical yan, the possibility of systemic beta blockade or beta receptor blockade must be considered. So how do we reduce the systemic absorption of drug? Again, we can occlude the nasolacrimal duct. So after administration, you have to tell the patient to occlude the nasolacrimal duct or simple eyelid closure. So this would reduce significantly the systemic side effects of drugs. So ito po yung mga systemic side effects like kasi nga beta blocker sila, they act in the heart kay beta 1, bradycardia, hypotension. Beta 2 is pulmonary bronchoconstriction and bronchospasm. And at some point, they can cause hypoglycemia. So ano po yung mga contraindication natin for the beta blockers? Of course, for the non-selective beta blockers, asthma and COPD in patients with bradycardia. So we have to avoid prescribing beta blockers to this group of patients. Okay? But again, we can choose to give the selective beta blocker. But again, based on clinical studies, they have reduced side effects. So these are the preferred agents based on the condition of the patient. Yeah. So sino po ang best in lowering the intraocular pressure? All the non-selective. Okay. All the non-selective except the cardioselective. So sino nga yung cardioselective? Betaxolol. Betaxolol. So avoid daw siya kasi nga cardioselective siya. For cost, sinong pinakamura? There are available Timolol generics. Okay, for comfort. Okay? Sino yan? Pag comfort. ISA, yung may ISA. 'Di ba, ang mga may ISA is less side effects. Maganda talaga yung kanilang safety profiles. So, carteolol. Carteolol. For hypercholesterolemia, also carteolol. Those with like allergy to preservatives, you can opt to choose specific brands like the one written. If you have COPD or asthma, okay, you can opt the cardioselective beta blocker, which is betaxolol. And then for pregnancy, you have to avoid all of them. Okay, so we are done with the beta blockers. Let's now move on to the adrenergic agonists. So the adrenergic agonists were discovered to be acting in the eye during the early 1920s. Okay, when they topically administer epinephrine to the eyes, it effectively lowered the intraocular pressure. So after discovering that, several adrenergic agonists were discovered and proven to be useful as ocular hypotensive agents. Okay? However, ano yung disadvantage ng mga adrenergic agonists? Okay, especially the non-selective alpha and beta agonists because of their relatively high ocular and systemic side effects. Okay, so like si epinephrine and the epinephrine, they are non-selective So they have high potential for both ocular and systemic side effects. That's why their use was supplanted by the use of more selective agents. So sinong mas preferred natin? Yung mga alpha-2 selective agonists. So if you opt to choose adrenergic agonists as treatment for glaucoma, you have to prioritize the selective agents, which include apraclonidine and brimonidine. So, let's discuss the two selective agents. Ano bang ginagawa nila? Of course, they activate the alpha-2 receptor. And as we all know, let's review. Ano nga yung alpha-2, mga doc? Is this a presynaptic receptor or a postsynaptic receptor? Can you help me? Presynaptic or postsynaptic? Okay, this is a presynaptic receptor. So activation of the presynaptic alpha receptor inhibits norepinephrine release. Okay, so therefore, the amount of norepinephrine available for receptor activation, including the postsynaptic beta receptor on the ciliary epithelium, is also decreased. So dual ang effect ng mga adrenergic alpha-2 adrenergic blockers, agonists. So anong ginagawa nila? They reduce aqueous humor, okay, production, tama, by activating alpha-2, but the alpha-2 found presynaptically or presynapse could also lower norepinephrine. So kapag bumaba si norepinephrine, that would also lower the amount of norepinephrine available for receptor activation in the beta-2 receptor, which is found in the ciliary epithelium. Okay, so that would also decrease the secretion of aqueous humor altogether. So, ganyan po ang advantage ng mga alpha-2 agonists when they are used for glaucoma. Okay? So, based on clinical studies, they don't enhance the outflow of the aqueous humor. They just reduce the production. Okay? So, ano pa? They also have additional influence on the blood flow. Kasi review tayo. Ano nga ang mga alpha-2 adrenergic blockers? Are they vasoconstrictors or vasodilators? Can you help me? Constrictors or dilators sila mga doc? They are dilators. Okay? So, because they are vasodilators, they could also have additional ocular hypotensive effects. So, sino yung dalawang to? Apraclonidine and brimonidine. So, based on radioligand studies, okay, it indicates that brimonidine is, okay, more selective, approximately 30 times more selective for the alpha-2 receptor than apraclonidine. So if they ask you which is more selective in the alpha-2 receptor, you will answer brimonidine. Brimonidine. Okay? So what are the documented side effects of the adrenergic agonist? So common ocular side effects associated with the topical administration of brimonidine and apraclonidine include conjunctival blanching, ano pa, eyelid retraction, and of course, my mydriasis. In terms of non-ocular side effects, okay, there are incidences of dry mouth, okay, or dry nose. For the systemic side effects, nabanggit ko na to during autonomic drugs, they can cause drowsiness and lethargy. Okay, so that ends uh, for the adrenergic agonist. So again, hindi na po masyadong ginagamit yung mga non-selective, but they have almost the same use with the selective adrenergic agonists. Let's now move on to the CAIs or the carbonic anhydrase inhibitors. Okay? Ano ba yung CAI or carbonic anhydrase? So carbonic anhydrase is an enzyme which is essential in uh, the conversion and formation of bicarbonate. So we have here, if you notice, may dalawa tayong Roman numeral, okay? Roman numeral 1 and Roman numeral 2. These, okay, two reactions are mediated by the enzyme carbonic anhydrase. So ano yung reaction 1 ni carbonic anhydrase? It converts carbon dioxide and water to bicarbonate. So sabi nila, high bicarbonate concentration can increase aqueous humor production. Okay? And then reaction 2 is bicarbonate is converted to proton and carbonic acid. So, saan papasok dito yung mga CAIs or carbonic anhydrase inhibitors? So, the carbonic anhydrase inhibitors can block the reaction 1. Okay, so pag binlock mo si reaction 1, carbon dioxide plus water will not be converted to bicarbonate. So, that will effectively lower bicarbonate. Therefore, okay, effectively lowering the aqueous humor production. Okay, so ulit, inhibiting carbonic anhydrase activity, particularly the reaction 1 in the ciliary process, is the most probable mechanism responsible for the aqueous humor, decrease in the aqueous humor formation produced by the carbonic anhydrase inhibitors. So production of bicarbonate in the ciliary epithelium appears to play a key role in the formation of aqueous humor. So in short, bicarbonate is associated with uh, aqueous humor production. So by inhibiting carbonic anhydrase, you effectively lower bicarbonate production. Therefore, effectively lowering also the aqueous humor formation. So, sino-sino po yung mga carbonic anhydrase inhibitors? All of them are ending in zolamides. Acetazolamide. Okay? This is administered, mga doc, by mouth, as tablet, capsule, or parenteral as injection. For methazolamide, it's only tablet. Okay? And the others are topical. Topical. So, sino yung mga topical? So, yung dalawa are systemic. Yung tatlo, okay, topical. Dorzolamide, brinzolamide, dorzolamide plus timolol. Okay? So, let's proceed first with the systemic ones or yung mga per-orally administered carbonic anhydrase inhibitors that include acetazolamide and metazolamide. So, pag tinake mo daw po sila, okay, as a capsule or as a tablet, okay, anong ginagawa nila? So they act on your kidneys, mga doc, okay? Aside from the eyes. So nag-a-act din sila sa kidneys. Okay, particularly in the proximal convoluted tubule or the PCT, wherein they increase the urinary excretion of bicarbonate by inhibiting carbonic anhydrase. So, tandaan niyo po, when they are taken systemically, they also act in the kidney, therefore increasing the urinary excretion of bicarbonate. I have a question. What does acetazolamide or metazolamide does in the urine? Does the urine become acidic or basic? Can you help me in the chat box, please? Basic. Because bicarbonate, correct, is basic. So it makes the urine basic. Correct. How about in glaucoma? So, si acetazolamide, this is typically administered in a dose of 250 milligrams every 6 hours, or a single dose of 500 milligram, uh, single 500 milligram capsule twice daily. Okay? For children naman, it's 5 to 10 milligram per kilogram body weight every 4 to 6 hours. Okay? So, pwede po bang gamitin yung mga per-oral KICE for long-term? No. So, in the treatment of elevated intraocular pressure, the oral acetazolamide and oral KICE are only often reserved for short-term intraocular, okay, pressure reduction only, short-term, okay? Because there are topical KICE now that can be safely administered for long period of time. So if you want a Kai that can be administered for long period of time, you have to switch to topical agents. Okay? So, sino ba yung mga topical agents natin? Yeah. So, bago pala, adverse effects muna or side effects. Ayan. First is, there is drug-induced transient myopia. Okay? Because acetazolamide is a derivative of sulfonamides. Sulfonamides. So, pag may allergy ka sa sulfonamides, doc, bawal kang mag-take ng KICE or acetazolamide because of the significant structural uh, differences and similarities in KICE and the sulfonamides. Okay? So, bawal kang mag-take ng ah ano ang sabi ko? Sulfonamides. Okay. Ayan. Ano pa? How about for the systemic? We have numbness and tingling of the extremities, like your finger, your toes. Okay? Yun yung mga nag-numb. Okay? Also, nagkakaroon ng metallic taste. Yeah, metallic taste. Ayan, nandito pala. Nakasulat. Okay? And GI irritation, like nagkakaroon ng abdominal cramps, nausea, diarrhea. Okay? And of course, dahil nilalabas mo yung ah, bicarbonate, nadideplete yung bicarbonate. So, nagiging basic yung urine. Tama? Kasi nilalabas mo nga. So, sa sistema mo, dahil nilalabas mo yung basic, ano nangyayari sa dugo mo? Nagiging acidic or basic? Can you help me? Okay. Because of, okay, it can cause metabolic acidosis. Okay? Metabolic acidosis. Bakit po nagkaka-transient myopia? Okay. Nabanggit ko na 'to because acetazolamide is derived from sulfonamides. So sulfonamides, all of them are causing transient myopia. That's a very common side effect of sulfonamides. So dahil parang kamag-anak niya yung mga sulfonamides, siya din nagko-cause. There are documented uh, side effects of acetazolamide. Okay? Yeah. And then, so kung napansin nyo mga doc, kung ano yung kanyang mga kapatid, yun din yung kanyang mga side effects. So, ganun po sa pharmacology, pag magkakamag-anak kayo, almost the same din yung mga side effects. Okay? So again, bakit siya nagka-cause ng metabolic acidosis? It results from the bicarbonate loss in the urine. Okay? Because of the renal actions of the kais. Okay? It causes the alkalinization of the urine. Okay? But the blood is deprived of bicarbonate, which is basic. So the blood becomes acidic or metabolic acidosis. So we are done with the peroral. Let's now move on to the topical agents. So pag sinabi natin topical, ito yung kanina si dorzolamide. So dorzolamide is the first commercially available topical carbonic anhydrase inhibitor to show significant ocular hypotensive activity. Okay, so topical KIs are generally well tolerated and they inhibit the isozyme 2 in the ciliary process, therefore reducing bicarbonate and reducing the aqueous humor secretion. Okay? So, ano po yung mga side effects nila? Ocular side effects include, of course, local irritation. Okay, so yung local irritation, it could be due to like pH or tonicity. Kasi nga, di ba, KIs could affect the pH. It could also cause stinging, okay, or even burning or foreign body sensation. Also, blurring of vision is also documented as one of the most common side effects of topical KIs. Okay? So, i-compare naman ngayon natin yung KIs, topical KIs, sa mga beta blockers. Okay? So, pag tinanong kayo, which is more effective in reducing nocturnal aqueous humor flow rate? Beta blockers or KIs, which is more effective in reducing nocturnal sa gabi gabi. KIs or beta blockers? Ano pa lang yung alam nyo? Ano yung sinabi ko kanina? Beta blockers are not effective during what? Suppressing aqueous humor formation during the sleep. Yeah, during the night. Specifically pag tulog ka. Okay? So, how about KIs? Can they reduce the nocturnal aqueous flow rate better than beta blockers? Yes or no? Yes. Yeah. Based on clinical study, it's about 25%. Okay? Yeah, 25%. Ayun oh, galing ni Doko. 25%. They are better in terms of nocturnal reduction, okay, of aqueous flow rate. Because again, the beta blockers lack this ability, okay, that occurs during the night or during sleep. So we are done with the Kais. Let's now move on to the last group of anti-glaucoma agents. We have the miotics or the cholinergic agonists. Okay, so the cholinergic agonists, as the name implies, mimic the effects of acetylcholine. So we can call them cholinomimetics, parasympathomimetics. And clinically, they are called myotics. So they are classified as either direct or indirect. So sino nga yung direct dito? Pilocarpine and carbachol. While ecothiopate is indirect. Okay? Si carbachol tsaka si ecothiopate, because of their side effects, they are rarely used now in the treatment of glaucoma. So most of the time, we can see uh, myotics as pilocarpine to treat glaucoma. Okay? So, anong meron kay pilocarpine? So, pilocarpine is extremely effective in opening the trabecular meshwork, okay, around the Schlemm's canal. That's why it could provide an immediate drop in intraocular pressure as a result of increased drainage of the aqueous humor. Kaya anong useful uh, indication ni pilocarpine? It has remained to be the most useful miotic, okay, in primary open angle glaucoma and acute angle closure glaucoma. It is also usually the drug of choice for emergency lowering of intraocular pressure during angle closure glaucoma. Okay? So, nabanggit ko na din previously that pilocarpine is an alkaloid. Okay? So, dahil alkaloid siya, uh, it is very, it is exhibiting affinity in the muscarinic receptors. So, tatandaan nyo, si muscarinic, it's disseminated around the body. Tama? So, ang disadvantage ni pilocarpine is uh, it could have systemic side effects. So, yun po yung pangit naman sa kanya. So, meron siyang mga peripheral side effects because of the systemic absorption following topical administration. Okay? So, ano po yung mga side effects ni pilocarpine? So, pilocarpine and other myotics, again, they are not frequently used anymore, but they have well-documented side effects. So, number one is accommodative spasm. Okay, so accommodative spasm is one of the most annoying adverse effect of pilocarpine and myotics, which can last for 2 to 3 hours after instillation of the topical pilocarpine. Kaya nga po, because of this reason na nagkakos siya ng spasm, patients less than 40 years old or younger than 40 years old, okay, find pilocarpine intolerable. So they cannot tolerate pilocarpine. So we usually, ayun na pala, nakasulat na. Okay, patient 1, younger than 40 years old. So, nagkakaroon sila ng spasm. Okay? So, lahat pa naman tayo dito, no? Pasok, no? Usapang edad. Ayan. So, we are still contraindicated to have pilocarpine kasi bata pa tayo, no? Ayan. Next, aside from accommodative spasm, some ocular problems could also occur, like meiosis. So, syempre, ano pa? It could also, pag kasi may meiotic siya, di ba? It could exacerbate cataracts. Yeah. So, contraindicated din siya pag may cataract ka because it's a meiotic. So, it can produce drug-induced pupillary constriction, which can visually incapacitate the patients with cataract. Okay? Yeah, at some point, it could also like accelerate the formation of lens opacities for patients with cataract. So nabanggit ko na po yung younger than 40 because of accommodative spasm, and some patients report refractive changes. Okay, yung mga bata na na-administran ng pilocarpine. Okay? Next. Bawal din siya if you have neovascular or uveitic glaucoma because it has a good systemic absorption. Okay? And of course, those patients with history of retinal detachment. So that ends our discussion for the anti-glaucoma agent. So, mga doc, do you have any question regarding the anti-glaucoma agents? You can ask me if you want to clarify